It's always a pleasure to be with you guys. We have a distinctive speaker today, Dr. Alessandro Papayannis, and Dr. Ahmed Elbarky, Dr. Prof. Marwan Aouammoh, and Samuel also. We will start with Dr. Alessandro, and I'm sure you'll enjoy this talk. So the mic is your Dr. Alessandro.
Hello to everyone. Thank you for the invitation. So, the aim of this presentation was introducing the updates on the clinical application of angio-CT. So, when I began my practice with angio-CT some years ago, this was the view, the panorama, the characteristics of the different angio-CT available on the market. And this characteristic changed progressively in the last years, and I think have no sense to make a table like that updated at this moment, because always new companies create angio-CT with different characteristics and different softwares. What we can see in this period in 2015, this is a patient with two patients with central serous retinopathy, and we find out in this period, the very beginning, 2015, that this kind of imaging was really helpful in this type of patients with central serous retinopathy, because we can see some types of new neovascular membranes that before we couldn't appreciate so precisely. And in these two patients that have been underwent both of them at half fluence PDT, we can see that one responds and the other not. And this one is a patient with a neovascularization that is clearly visible on angio-OCT here. The other one have nothing like that. So in 2013, we didn't have angio-CT. And this was assessment of a patient with chronic epitheliopathy, central serous retinopathy, complicated in the right eye from a CNV. This is the fluorangiography, the ICG, the blue light autofluorescence here, and this is the near infrared autofluorescence. This was the follow-up of this patient with the OCT structural B scan with Heidelberg, with a follow-up application from 2013 to 2016. And we see here this CNV that we appreciated before on fluorangiography and ICG that respond to treatment with anti-VEGF, the subretinal intraretinal liquid disappear and come again according to the treatment. In 2016, we have the opportunity to try a prototype of angio-CT made from Heidelberg that wasn't commercially available in this period. We tried to use this angio-CT to this patient, and the first thing I have done to this patient is to plan a big scan, a wide scan, in order to include this big, in my opinion, neovascularization. But we couldn't appreciate something with clearly a clear neovascular membrane. And in the follow-up with clear activity on the B scan here with intraretinal liquid and exudation, the situation was always the same. That before, because we have done a really huge scan, but with really low resolution. We can see here in the corner the resolution in the bottom on the right of your screen was only 30 micron. The highest resolution that this machine could use was 11 micrometer. And with 11 micrometer, we can see here that is clear visible the presence of a neovascularization. And this is the image of the same patient with the commercially available angio-CT of Topcon in the same year. And we can see here this kind of neovascularization in the outer retina and in the choriocapillaris. Even when the situation was quiet without intraretinal liquid, we could appreciate this membrane. So, and this is the left eye without any kind of neovascularization, and this is always the right eye. So there is, in this point, I want to focus your attention on something. There is a resolution that is critical. We need at least 8 micron of lateral resolution when we do angio-CT, because otherwise the risk is we can appreciate 2 different vessels as one. So we need at least 8 micron of resolution, and the aim of Heidelberg was to improve the resolution to a 5.7 per 5.7 lateral micron resolution in order to have the clearest capacity to visualize this type of new vessels, or also the normal retinal vessels. And this is an example of the resolution with the Heidelberg at the moment compared with Zeiss-Plex Elite 9000. We need to say thanks to Heidelberg for this type of images. And you can see that if we compare Heidelberg with a competitor that is a swept source of CT, the Zeiss-Plex Elite, you have a really high resolution of the also of the smaller vessels of the retina. So this is the same patient in November 2019 with the commercial available OCT angiography of Heidelberg, and we can see now clearly this membrane that neovascular membrane that we can see previously. This is the part of the neovascularization that is not active. It's like a tree without the lateral small vessels, and this is the area that is still active, the front of that's active of the neovascularization. And we can see also the flow in yellow here in the OCT A/B scan, and this is the left eye without any type of neovascularization, but with the subretinal liquid of chronic central cerebral retinopathy that have also in the other eye. And these images have 6 micron of resolution, as we can see here. But in order to have this type of resolution, we need to reduce the width of the scan. This, what we can see here in red, this red box, is an area that cannot be scanned in the same session, because the amount of the data is really big, and the instrument cannot do buffering. So you need to use only this small blue area. And we can see that in the follow-up, using the follow-up scanning plan tool, we see that the neovascularization have a new front in this case on the bottom, on the left. But we can see that this is a really big neovascularization. And with this type of scan, we have difficulty it's difficult to put all the neovascularization inside this box of scan. But we can see that with this high resolution, we can appreciate that there is a new front of activity. We see in the B scan that the intraretinal liquid is increasing, and we can see this with the follow-up, this new front here. This is with 11 micron, and with 11 micron resolution in the same patient, we cannot see clearly this kind of neovascularization that expands. There are other instruments, especially the swept source angio-CT, that can do really wide field scans. But also with wide field scans, we have some difficulties. And as far as we go to the periphery, due to the curvature of the eye globe, we need to have a Z-plane that is really deep, because otherwise in the extreme periphery we have these artifacts due to the curvature, and we lose the image. And this is an example with Angioplex Zeiss Elite, this reconstruction, and we can see here this type of artifacts due to the curvature of the eye, because the scan is not deep enough to include all the retina. And also, as far as we go to the periphery, the retina gets thinner, and we have also artifacts, as we can see here in this green rows, artifacts due to the difficulties of segmentation. Can you hear me?
Yes, we can hear.
Okay, because I lost my image, okay, on the screen. So we have some artifacts due to the segmentation of the retina that is really thin. We can do imaging of the periphery of the retina in some disease as diabetic retinopathy with different modalities. We can create a mosaic, as we can see in this reconstruction that we present in ARVO annual meeting in September 2016. But we can do not only a mosaic and a full reconstruction of the retina, but we can also do a scan with angio-CT only of an area of interest. And this is an OCTA scan in the periphery. We can see this type of abnormal vessels. If we do an angio or CT in this area, we can see that this is a neovascularization that grows on the top of the retina. So the swept source angio-CT have the ability to detect new vessels till the limits of an Optos California ultra-wide field of FA acquired in the primary position. So we can go in the very extreme periphery, and it's not necessary to make a mosaic and a full reconstruction. We can make a scan just in the area that we need to investigate. This is this idea follows Heidelberg, and Heidelberg with the scan planning tool permits us to plan a scan in an area of interest. In this case, in a patient that underwent first fluorangiography, after we can plan a scan with angio-CT only in the area that we want to study, and we can see how the neovascularization disappear with the follow-up without the need to repeat again the fluorangiography. We used this type of extreme periphery study with angio-CT in this case. This is an hemangioma, and you can see here the washout in the late time of fluorangiography. And we scanned the area of the hemangioma, and we can see here the vascular alterations in the choroid in the area of interest. In this case, we need to do a really deep scan because, as we can see, due to the curvature of the lesion, the scan needs to be really deep. Otherwise, we can have important artifacts of segmentation.
And this is for clarification, Alex. This is only a swept source can do that, isn't it?
So this is with the spectral domain in this case. But the spectral domain, as we can see here, this is the maximum of this is the widest scan that you can have with this instrument. And in order to have a so wide scan, you need to decrease the resolution, as we can see before, as we see in the previous case. So with this one is with the spectral domain with the swept source angio-CT with the TopCon. The TopCon have a software that can show us the vascular density, and this was really helpful in cases with choroidal hemangioma. And this is a paper presented from Indian authors. We used the vascular density in patients with AMD, and we found out that also in patients with this is the normal vascular density of the chorocapillaris in a normal eye. And here in patients with drusen, we see that the vascular density is alterated. You can say that this is artifacts, but not with, if you use a spectral domain, the signal is blocked from the drusen, but with the swept source OCT, the signal pass really nicely through small drusen like that. So this is not an artifact. This is an alteration of the vascular density in the area where we have the drusen, and not only in the chorocapillaris, but as well we find this type of alteration of the vascular density also in the superficial retinal layers. And similar alteration we have also in dry AMD with atrophy, as we can see here, in both the choriocapillaris and the superficial retinal plexus. This is another case with small drusen and atrophy, the choriocapillaris and the superficial retinal plexus. So this is another example of alteration, or in this case, not of the vascular density only, but also of the vascular flow. This is a patient, a young patient with a torpedo maculopathy. This is the blue light autofluorescence, the near infrared autofluorescence, the OCT, and we perform with a Zeiss angio-CT, an angio-CT of the lesion, and what we found out is that this area have not flow in the choriocapillaris. So this
slide, Alex?
Yes.
Can you move, because we have a fixed slide here.
Yeah, I don't know why it's where we are now. Oh God.
We are on the Californian image in the accepted manuscript of class 3.
I'm talking since a lot and is always in the same position. You could stop me before. What is going on with this? 1 second.
Maybe you should stop sharing and reshare again if you, okay. Great.
Yeah, but I think we need to go a little bit before, because I think.
Yeah, in slide 25.
It was this slide.
Yes,
Since this slide, we stop the sharing.
If it doesn't move, you can keep it on this setting if you like.
I will show you quick. Oh my God, sorry. Well.
25.
Do you want I show you quickly these images? 1 second. So.
Okay.
It was here. This was the artifacts of segmentation we talked later.
Now
there are different modalities to go on the periphery with a mosaic, or we can do scans only in the area of interest. This is a Optos fluorangiography in the primary position, and we can see here nicely how with the angio-CT we can see the neovascularization of this area. And here, this is the scan planning tool of Heidelberg. With this tool, you can program, you can plan a scan in the area of interest, and you can see the follow-up of this type of vascularization with the planet scan of the area of interest, and we see the regression of vascularization here in a diabetic retinopathy, proliferative diabetic retinopathy. This is a patient with hemangioma I was talking to you before. The reconstruction of the ICG on the periphery. This is the hemangioma.
Yeah.
The washout in the late time of the ICG and the autofluorescence. And here is a scan with Heidelberg of the area of the hemangioma. This is a wide scan, but with low resolution. But we can appreciate the alterations in the choriocapillaris with this scan. This is a projection artifact due to the presence of this retinal vessel that normally in this type of segmentation will not appear. This is an artifact. So this is now changing. We move to the swept source angio-CT. The swept source angio-CT, as I talked to you before when the image was freezed, have a software that can make a map of the vascular density. We can use this vascular density map in many diseases. These authors used this software in patients with hemangioma to appreciate the alterations before and after the treatment with PDT of the hemangioma, of the density of the vascular alteration. We used this software in patients with IMD. This is the normal vascular density of the macula in the choriocapillaris in a normal eye. This is a patient with drusen, with dry AMD. And we can see here that the vascular density is not normal, is alterated in the areas where we have drusen. This is not a projection artifact, because we can see here that the image is really clear without any shadowing effect due to the presence of the drusen. With spectral domain OCT, you have this type of problems of shadowing effect, but in this case, the swept source have a really strong signal that can pass through small drusens, pigment epithelium detachment due to drusen, as in this case. And we can see that the vascular density is alterated also not only in the chorocapillaris, but as well in the superficial layers. And also this happened with patients with atrophic AMD or in patients with combined atrophic AMD with drusen. And we see that both chorocapillaris and superficial retinal plexus are alterated in this type of patients. So this is the case of torpedo maculopathy. In this case, we can see the alteration of the blue light and near-infrared autofluorescence in the area where we have the torpedo maculopathy. And with the angioplex Zeiss OCT angiography, we can see that in the area of atrophy, the flow in the chorocapillaris is alterated. We don't have any type of flow in this area. The same thing with another type of scan. And we use it also the AngioView, AngioCT in this case. We found out also in this case that the flow in this area is abnormal. We don't have choriocapillaris in the area of atrophy. And the same thing with the swept source AngioCT of top cone. Also the vascular density in this area is alterated. So we don't have vessels. And this area of atrophy in torpedo maculopathy is due to not a normal development of the choriocapillaris in the area of interest. This, the blood flow, the angioflow, is useful also in diseases as in uveitis, and this is a paper recent published that show that in these areas we have alteration of the flow, but in my opinion, here we have a shadowing effect. And when this material disappears after in the chronic phase, you see that the flow comes again. So I'm not totally, I don't agree totally with what these authors describe, but now in this moment we have this type of perfusion density also with the swept source AngioCT as the top cone. This has been developed in the last 2 years, and in this case we can avoid this type of shadowing effects. This is the normal perfusion density in a normal eye, and we found out that the perfusion density, so in this case we talk about flow, not about just presence of vessels. The flow is alterated, was alterated in patients, is a patient with deficiency optic neuropathy. So this is a normal eye. We can see here in this patient that have a deficiency optic neuropathy, that is the temporal blood flow density is alterated, and this is associated also with an alteration of the optic field, of the visual field in this area. Similar works have been done about the perfusion density in other diseases that have to do with the ischemic alteration of the optic disc. And we see here that the alteration of the visual field is associated with alterations of the flow of the AngioCT in the areas that of interest where the visual field is alterated. And not only, we can find also alterations of the foveal vascular zone in patients with high blood pressure. And this is the patients at the very beginning of the natural history of the hypertension. And as far as we go forward with the years of follow-up, the patients that have hypertension for more years have a larger foveal vascular zone associated with alterated blood flow around the optic disc. And this is another study done from a Brazilian author in patients treated with anti-VEGF for macular edema. And this this is when we have this image is with the macular edema. It's not, we cannot say that the vascular density improves after the treatment, but here we have this lower vascular density and vascular flow because of the presence of the edema that creates problems in the segmentation of the area, and this is an artifact. So there is no alteration after anti-VEGF of the blood flow and of the blood perfusion density on angio-CT after treatment in macular edema or in peripheral diabetic retinopathy. There is no decrease or increase of the density or of the foveal vascular zone. Finally, I want to show you how we can use angio-CT in patients with disease as retinitis pigmentosa, Stargardt disease, vitelliform dystrophy, choroideremia, and best vitelliform disease. We can see that all these patients have an alterated foveal vascular zone. This is an article published from Maurizio Battaglia Parodi et al. We published it as an article on X-linked retinoschisis, where we found these microvascular alterations in the intermediate layers of the retina, associated with this typical alteration also of the foveal vascular zone and of the B-scan angio-CT. And I want to end up with this case. This is not macular dystrophy. This is a kid that plays with a laser, with a pointer laser, through a mirror. This is a kid with hyperkinetic problems, and he pointed the laser against his eye through the mirror, and he made this kind of alterations, as we can see here, of the pigmentation that we can appreciate not only in near infrared and infrared autoreflectivity, but as well a little bit in blue light autofluorescence. And we perform in this patient angio-CT. What we find was that the vascular density and the vascular flow was alterated permanently. So during the follow-up of 6 months, the chorocapillaries present this alteration that was permanent. The visual acuity was low in this kid, but what we have done was to do using the microperimetry. We have done a sort of rehabilitation of the point of the fixation point, and after this fixation training, the visual acuity improves from 4 to 9/10. So I want to end up telling that it's not important what type of angio-CT you use. You need to know that any machine, any instrument has different characteristics, and we need to know how to use to the maximum these characteristics. So it's not important which machine you select, but it's important to know how to use it to the top. Thank you very much.
Thank you very much, Dr. Alexandros, and this was wonderful presentation. We enjoy the slides that you bring it, and some of the question is, you was mentioning that as much as we have a wide field of OCT, as much we have a less resolution, so we cannot have both together.
Yes, this with the Heidelberg, that is a spectral domain. We can make wide scans at the moment with available technology, but we need to reduce the resolution. With the swept source angio-CT as angioplex or TopCon angio-CT, we can do wide scans with the same, always with the same resolution. And now is commercially available this swept source OCT from Canon that will be really interesting to use and to try. But the point I think of force of the swept source OCT is that they can do really quick scans and wide scans that the spectral domain OCT cannot do at the moment.
I see. That was a wonderful. Even the suggestion of using the OCTA for the central serous chororetinopathy, if there is for follow-up or if there is any documentation, because some people believe there is a source for new vessel for any central serous chororetinopathy. I think OCTA can give you a clear image whether there is a new vessel or there is no new vessel, so you decide what to treat with.
I think we need to rethink about the classification of OCT, of central serous chororetinopathy, according to the findings on the angio-CT and the ADI OCT that show us characteristics of the choroid and of the chorocapillaris that we couldn't appreciate before. We can speak nowadays also about the pachychoroid diseases. And so we realize that there are some new type of diseases that we can treat in another manner, for example, with the anti-VEGF, that previously we was thinking that are not needed in diseases central serous chororetinopathy. So when we have this type of neovascularization, anti-VEGF are helpful, and they're not enough in many cases. In many cases, we need also to do as well PDT combined with anti-VEGF, low flow, half flow PDT combined with anti-VEGF.
Last practical question, Dr. Alessandro. If you have a limited budget and you have your clinic for diabetic, which type of OCT you're going to buy? Are you going to buy the spectral domain, or are you going to buy the swept source, or are you going to buy the ultra-wide swept source, especially if most of your patient is diabetic?
Yeah, look, in this moment, what I'm realizing is that we use always more fluorangiography for diseases, diabetic retinopathy or branch retinal vein occlusion. And for CNV, there are really few the cases that we need to do a fluorangiography or an ICG, because OCT and OCTA can give us enough information. As far as the scans of the angio-CT are not so wide to arrive to the extreme periphery, the gold standard will be the fluorangiography. So OCTA cannot be superior to angiography as far as cannot arrive to the extreme periphery. We have seen through this presentation that we can arrive to the extreme periphery, but it's not so easy. So in this case, if you need to select an angio-CT to use it in the extreme periphery, in my opinion, is better a swept source. And especially because the strength of the signal of the swept source OCT is always the same from the vitreous till the choroid. And from the other hand, the spectral domain needs to work in a different plan, and you need to focus. So if you want to work in something that grows up on the retina inside the vitreous, you need an instrument that have a signal that have always the same strength. So swept source OCT is better, is quickest, and can have widest scans. We have done a publication on European Journal of Ophthalmology that will be soon available about the segmentation of the vitreous in diabetic retinopathy. And according to different type of segmentations, we can find that the neovascularization due to proliferative diabetic retinopathy can be active or not. And I hope in another occasion we can speak, we can have 10 minutes to present this publication, but in my opinion, it's really interesting.
Thank you very much, Dr. Alexandros, for this wonderful presentation.
Thank you, Abdullah. I apologize that we have this problem with the presentation that was blocked, but I think
it was very good, very good.
We arranged it.
Very good managed. Thank you very much, Dr. Alexandros, and we are glad to have Dr. Ahmed Elbarky with us with a very nice presentation. I'm sure you will enjoy the market here, Dr. Ahmed.
Thank you, Dr. Abdullah. It's really a pleasure to be here with you in this interesting meeting. I'm just going to share with you some surgical cases, and please let me know for the time's sake, because I think we are exceeding the time, so I can share. I'll start with one case, intraocular foreign body removal, using what we call a double shake hand technique. Just for the sake of time, let's go for the presentation. This is my intro for my videos. But we need to be fast.
Always cinematic.
No, just so this case is a small gauge vitrectomy for intraocular foreign body. using, I don't know, the music will go away now, don't worry. Using what we call double check technique. So this patient has a trauma with intracorporeal body metallic, and he was repaired. The scleral wound was big actually, and 5 or I think 6 days later, we go inside trying to remove the intracorporeal body. And you can see here how the conjunctival periotomy was huge because the scleral wound actually was big. So we start doing removal the cataract first, and there was no issue with the cataract because, as you see, this young patient, I think he was 30 years old, so it's soft cataract. But in this technique, using the removal the intraocular foreign body with a small gauge, in this gauge we use 23 gauge, you need to remove the cataract or remove in the lens to allow you to remove it through the anterior chamber. So we start doing the phaco. It was, as I told you, soft cataract. Let's go fast a little bit. It's not the interesting part. So we go with the phaco, as you mentioned, that we use. I didn't use even chopper because it's soft, so we use only high vacuum. Even you didn't need to track. It was very soft cataract. So after that, removal the cortex, and for sure, after cleaning the cortex and the posterior capsule, you put viscoelastic to inflate the bag, because later on we need the posterior capsule to be separated from the anterior one. And then I take one stitch temporarily because we don't want any leak or any hypotenuduric surgery. Or so you suture it, and then we start our surgery, going for the intraocular and trying to remove the foreign body. If you look here, after doing vitrectomy and the removal of the posterior hyaloid, you see here the intraocular foreign body was a little bit peripherally, and trying to vitrectomy here. And I appreciate if you can, he has a look on the reflex of the macula here. I think this is because of the heat effect of the foreign body before impacted periphery like that. So after doing that, we need to do posterior capsulotomy to give a bath for the intraocular to be removed through the anterior chamber. And this is the foreign body inside the eye. You can see it's a big one, and it's irregular in shape. And this is very tricky here. So you hold it inside the eye, and you see how big is it. And the problem now is, so here now I hold, let's pause the video here, because here I hold the foreign body with my right hand. And if you look again, you find that the intraocular foreign body has a curvature. So if I try to deliver it in this way, the foreign body definitely in not a proper position, so it will definitely hit the endothelium. So what I'm trying to do now, I cannot deliver it in this way, so I have to put it back after putting perfluorocarbon and then use chandelier lights, because I want to hold it in a way to allow me to deliver it safely with the curvature matching with the corneal curvature. So while delivering to anterior chamber, it will go smoothly without injuring the endothelium of the cornea. So here, this is the first check hand uh, technique or step I did intravitreally, using both forceps, trying to adjust or hold it in a way to allow me to deliver it to anterior chamber safely, avoiding injury of the endothelium. So after holding, I hold it in my left hand now. I found it's more convenient for me. Now we remove the assistant removed the biome for me. And if you look here now, I hold it in a proper way with the curve matching with the corneal curvature. So now I remove the chandelier light. And here I want to stop here, but to comment a very important point. Here now, I'm going to try to remove this anterior chamber. So I'm going to enlarge the corneal wound. So there is a sort of positive pressure and the iris overlaps. So this is a very important point here to adjust your intraocular pressure. Either using you can use a vent if you are valved trocar, or you can cancel the IOP control of the machine, because you need pressure, the inflow always equal to outflow after enlarging the corneal wound to avoid iris prolapse. So going back, so now I hold it with my left hand, and now definitely there's some viscoelastic, but it drops away. Sure to have to be careful from the cornea. With the other hand, you enlarge the corneal wound, and try to make it bigger than the foreign body, because you want to stuck at this step, because it's very, so 1 millimeter more it's not. And with the other hand, with the big forceps, hold it deliver it. So this is the second check hand step. And with this big forceps, you can hold it and get it out. Again, if the pressure, you have to control the pressure, and quickly you have to reposition of the iris, put a viscoelastic, and you can see here also the anterior capsule was injured here. It's expected because it's a very big and irregular forceps foreign body. So, but you have to put the 3-piece and make sure to put the haptic away from the tear in the anterior capsule. After that, we suture it. We suture the cornea, and you have to be a little bit fast in this step because you don't want hypotony too much time. And after that, you will go back to complete our surgery, remove the peripheral carbon, and doing peripheral vitrectomy at the and for sure we do endolaser around the trimming for sure the retinal tear superiorly. As you can see here, it's a very peripheral, you need to indent. And it was I was lucky because the tear was superior. So in this patient, in this case, I used gas because there is no retinal detachment, just the tear, and also the macula was despite the fact of this heating effect, it was a little bit healthy, and the disc is okay, and the vision, actually, the patient improved, and the vision see a lot. And so the idea here, this is a air fluid exchange, and we put it then in on gas. So this is my first case. And the idea here, if you can use a small gauge vitrectomy in foreign body, you will and manage to remove it through the cornea, I think you will save the sclera, which is already have a big wound before. So I think it's more forgiving rather than make another very big sclera wound to remove such a big intraocular foreign body. This is my first case. Shall I continue, Dr.? Do we still have time, I think, or we stop at this stage? Dr. Abdullah.
Dr. Ahmed, you can do the second case, please.
Okay. Second case is the interesting case. For sure, I stop again. No need to see this again. It's a vitrectomy in Terson syndrome. This patient. So this patient, 44-male patient, traumatic intracranial hemorrhage, subacute decreased vision, right eye, and later after he made the surgery and he is stable, we examine him and we find he has a dense vitreous hemorrhage on this side. So doing vitrectomy, starting the vitrectomy was simple in terms of vitreous hemorrhage. You can see the hemorrhage. You just remove the hemorrhage, and we find here a lot of exudation there. At this stage, everything was fine. Just to go a little bit forward, just want to show you this is the most important. Now, after removal, trying to remove the subhyaloid hemorrhage and the posterior hyaloid, you can see here there is a ring of exudation behind, or exactly at the macula. So after I'm trying now to separate the posterior hyaloid using a 25 gauge beveled. Just this is some funny thing here. You can sometimes you can use the vitrectomy probe as at the tennis racket. You catch the clot before touching the retina. This is something funny. It's not real. Anyway, so we remove the posterior hyaloid now, and what was interesting that this ring yellowish exudation or deposition at the macula. So after completing vitrectomy peripherally, I go approach trying to activate the vacuum, only trying to absorb it, but it was not. It's not under. It's well under actually. It's not on the surface of the retina. It's not premacular. It was actually under. And what happened here? I cut the internal limiting membrane with a vitrectomy probe. And this lipid deposition, or this is chromic was, and you can see, I'm just trying to show you here, this is the edge of the internal limiting membrane. So I was trying to aspirate, but I think at what happened, I make a tear in the internal limiting membrane. And because it's very, I was lucky because, in Terson syndrome, the blood, what happened, it goes up under internal limiting membrane. It's doing something what we call hemodissection of the internal limiting membrane. So there is a space between the internal limiting and the retina. And this is also one of the advantage also of the using a small gauge, especially the beveled tip, that you can very come closer. Now I'm trying to aspirate it with the, after making the opening in the internal limiting membrane with the vacuum, but it was not coming smoothly. So at that time, I decided it's better to use the back flush rather than that. So with back flush, I'm trying to aspirate it, but it's still very thick, cannot come. So the other way around is to just flush it with the back flush to remove the, to decrease the density of this one, and then aspirate it later on. And after that, we finish with this one. I just make a stain just to make sure to have a look on the remnant of how much I take from the internal limiting membrane using the vitrectomy probe. After that, you will find that almost the whole internal limiting membrane was removed using the vitrectomy cutter during the aspiration and this maneuver. But there is some remnant here, and you can see here what we call it the double macular ring sign, which is typical in Terson syndrome. So I complete the ILM peeling outside the arcades. Actually, there is no need to do that, but once you get inside, you have to remove the completing vitrectomy peripherally and air fluid exchange, and I left this on air. Actually, there is no attachment. So if you go to the literature about that, you'll find some the same finding, this ILM subretinal hemorrhage in Terson syndrome, and also the double ring sign or macular double ring sign that was that. So I'm just sharing the case with you. To sometimes we don't see a Terson syndrome a lot, but in such case it was my first time. But just to see how we manage it properly. And this is my second case. And I think Dr. Abdullah, if to give more time for the other speaker, because we start, I think I can stop here.
We'll start with Dr. Prof. Marwan after just a few questions to you. I see your nice presentation and wonderful how much difficult to suck it with the vitrectomy. I don't think sucking the subretinal hemorrhage, especially chronic one, with the vitrectomy is wise, except if you have a small gauge. So with a small gauge, you have a small tip, you can maybe control to grasp the ILM membrane and peel it. But it's, as you show it very nicely, that it's not easy to suck it with a vitrectomy. And actually, what we do now, because we see frequently those cases of chronic subiolum hemorrhage in leukemia. And we go for flash, actually, directly with the back flush, because we have tried before that it's very difficult to suck it, and sometimes it's a little bit dangerous. Otherwise, it's a wonderful technique, Dr. Ahmed.
Thank you. Thank you so much.
Last thing question is, do you inject when you do vitrectomy plus phaco? You start with the phaco first, do we agree?
Sure.
Then do you put the IOL at before the vitrectomy end, or just you do the injection of the IOL before the vitrectomy or after?
No, in my case, the foreign body, I have to do it after removing the foreign body, because I will open the capsule and remove it. But in some cases, in retinal attachment, for example, combined for a simple vitreous hemorrhage, you can implant the IOL and then do vitrectomy. But some kind, if you want to do work peripherally, I think putting the IOL before starting vitrectomy, the edge of the IOL would affect your visualization for the periphery. So it's better to complete the vitrectomy and then put it at the end. But in this case, I'm obliged to do that. I cannot keep it at the end, because I want the path for the anterior foreign body to go through the capsule. That's it.
That's great. And I actually, what we advise for attendees is when you have a simple case, injecting the IOL and finish the phaco may be easy, but as you proposed, Dr. Ahmed, suturing is very important, because you don't want any leak from the anterior chamber. Otherwise, dislocation, tilting of the IOL could be there, especially with the air fluid exchange. So suture is a very good precaution and technique.
And one more point, Dr. Abdullah, also one more point. If you're going to combine, if you are going to start with phaco first, you have to insert your infusion first. Just not the infusion, I mean the trocar only, because after you do the phaco, the eye will be soft, so it will be struggling to do the tunneling for the trocar. So put the trocar first, the opening with the normotensive globe, and then do the phaco, and then you can have access to the procedure.
So just 3 points in that technique. Number one, you delay the injection of the IOL whenever you have a foreign body, so you want to take it out through the capsule without interrupted by the lens itself. Number two, if you have a difficult cases and you want to see the periphery, and sometimes with the rim of the lens itself, you cannot really visualize the periphery.
The equator will bother you.
And you should make a smart move by doing a small capsulexis in which the capsulexis itself, anterior capsulexis, will hold the IOL lens. Otherwise, it will be stuck there if you have the haptics in the capsule, but it's easier to be controlled by this way.
Yeah, exactly. Yeah.
Was a wonderful presentation, Dr. Ahmed. You always
thank you.
Have a cinematic sense.
Thank you so much.
We will be happy to welcome Prof. Marwan Aouammoh, and the mic is your, Prof. Marwan.
Thank you. So I'll talk about the ocular trauma and intraocular foreign bodies in a quick manner. We saw a nice case by Dr. Elbarky. To start, it is important that to maintain a unified terminology between the patient, between the doctors, that we apply the Birmingham eye trauma terminology, and intraocular foreign bodies or retained intraocular foreign bodies are considered a subset of penetrating injury, as you can see in this algorithm for the BIT terminology. Most intraocular foreign bodies seen are usually in the posterior segment. So most likely they will end up in your clinic or referred to you by the consultant or by the attending who did the primary repair. And the goal is to remove the foreign body restoring the ocular architecture with preserving the vision. The most common sites of entry for the posterior segment intraocular foreign bodies are usually the cornea, then followed by sclera and the limbus. So the pathophysiology of the intraocular foreign body is that it causes mechanical damage, usually either the sclera, cornea, or both. The cornea usually is a little bit better from our point of view, because this means that it didn't pass through the uveal tissue or the retina. Blunt foreign bodies usually travel a shorter distance inside the globe, but at the same time, it will damage the site of entry more than the sharp objects, because the sharp objects contain the energy and they will damage the site of impact more than the blunt foreign bodies. The longer the wound, the worse the outcome. This is a prognostic factor that is well known. Intraocular inflammation is another problem with intraocular foreign bodies. Whether the object is metallic or vegetative material differs in the amount of inflammation that you will have. Trauma to the iris will also cause some inflammation. In addition, exposure of lens material when the lens is injured will end up with phaco-anaphylactic and sometimes PBR if neglected. Of course, as part of the intraocular inflammation is the traumatic endophthalmitis. These are factors that increase the risk of endophthalmitis. We already have the retained intraocular body. In addition, the breach of lens capsule, the dirty wound, the delayed presentation, and the delayed primary repair, in addition to the rural setting, all increase the risk of endophthalmitis. Then we have the metallosis. So siderosis caused by iron and chalcosis caused by copper are very critical, and usually the siderosis would take time while the chalcosis develops quickly. And sometimes you can even identify it with, in the cases of siderosis, you can identify the toxicity by ERG with, before any clinical evidence for the siderosis, by an initial or initial increase in the A wave, followed by progressive reduction in B wave, and lastly, the ERG will be distinguished. Obviously, the history is an important part of the management of the patient, to identify if there is really a foreign body into the eye or not. Tips in examination like focal lens opacities, pupil or asymmetry, high-risk heterochromia in cases of chronic intraocular foreign body, and small self-sealing wounds are signs of an intraocular foreign body entry. Obviously, in the acute setting, you should avoid scleral depression, gonioscopy, and doing a B scan. Radiography, and in the form of X-rays, is considered a screening tool, but the gold standard is usually the CT or the computed tomography. Usually, the radiologists tend to do a bone window with the CT, and this will help you in identifying metal objects. But when you are suspecting less radio-opaque material, you should ask for a soft tissue window. In addition, certain plastic, ceramic, or even wood can be difficult to visualize with CT scans. And very tiny ferromagnetic intraocular foreign body that cannot be identified by X-ray, CT, or B scan it might be safe then to order an MRI, a 1 Tesla MRI, that hopefully wouldn't cause any further intraocular damage. Ultrasonography is a little bit guarded because of the fact that the eye is open in the acute situations. So this is an X-ray of a patient who presented to us with a trauma and an intraocular foreign body. This is after this X-ray was done after the primary repair. You can see that the metallic foreign body is not clearly identified. The place is not, or the site is not clearly identified in this X-ray. While when you do an OCT, you can see it resting well inside the globe. So what about surgical management? So after taking care of the patient's other acute injuries and stabilizing the patient, you can consider the following: the size and composition. In small metallic foreign bodies, it is easily to remove them with an intraocular magnet. In cases of non-ferrous or non-ferromagnetic foreign bodies, sometimes you can use the vitreous cutter alone, or use the forceps to extract them. In more larger or glass foreign bodies, then you need to have a diamond-coated forceps. In large metallic foreign bodies, probably that are difficult to remove with the intraocular magnet, then you'll probably need the giant external electromagnet. The entry wound usually is not recommended at the site for intraocular foreign body removal, as we have seen in the case with Dr. Elbarky's video. And retinal examination after removal with scleral depression and checking for tears, retinal detachment, and or choroidal detachment, and dealing with them in the same way you would deal with any trauma or retinal detachment cases of utmost importance. Gas versus silicone oil, there is usually no preference, but it's left for the surgeon to choose, as well as for the encircling band. Obviously, complications after vitrectomy that may happen, or you should keep in mind, can vary from simple hyphema and cataract to sympathetic ophthalmia in the other eye. For prognostic factors, and this should be put into consideration with every intraocular foreign body case, and to sometimes discuss with the patient, so you have the visual acuity at presentation. The better the visual acuity, the better the outcome, obviously. Larger wounds have worse outcome. Endophthalmitis at presentation are usually having a worse outcome, and we will see a video of a similar case with a similar presentation. Wound larger than the intraocular foreign body in its largest length is considered a bad prognostic factor. Vitreous hemorrhage is also a bad prognostic factor. In addition to the presence of retinal detachment, uveal prolapse, and the presence of APD at presentation. So definitely for acute intraocular foreign body, you need to remove them. If you weigh the benefits and the risks, it's definitely towards removal of the acute intraocular foreign body, but you may need to consider when to remove or the timing of removal of the intraocular foreign body. This is not the case with chronic retained intraocular foreign body, where you should weigh the risks of surgery-related complications versus just leaving them the intraocular foreign body behind. This is a small table that shows, in the case of acute intraocular foreign body, to whether to remove the risks or the variable that are considered for immediate versus delayed removal. Delayed being at most 2 weeks, 10 to 14 days duration. So we can see that endophthalmitis risk increases with delayed removal, while the risk of having an expulsive hemorrhage would be high in the case of immediate removal. So in the hands of less experienced surgeons, maybe you want to delay the intervention, to plan ahead of time and put a plan for how to approach this foreign body. In addition to having time to plan, this time will allow spontaneous posterior highlight detachment in some cases, and allow for the cornea to heal and the edema to go away. There is no statistically significant visual and anatomical difference seen whether the vitrectomy was performed during the first or second week after injury. But you should consider many factors, especially in the cases where you have intraocular foreign body penetrating the back surface of the eye, where part of it is hung inside the vitreous cavity and the other side is within the sclera or into the orbit. And for instrumentation, you can either use the external electromagnet, the intraocular magnet that utilizes the rare earth magnets, and many kinds of forceps, whether basket or serrated or diamond dusted. This is a photo of the external electromagnet. This is an old external electromagnet. Usually it weighs like 1.5 tons, and it's difficult to mobilize on top of the patient's head, and it was not usually very convenient. Now we have this giant magnet. Usually you need to hold it with both hands, and it is the beauty of it is that the angle, you can hold it at whatever direction you want to choose in order to line the axis of the power of the magnet in line with the wound and the foreign body, thus reducing injury to other parts of the eye. The rare earth magnet is available in many gauges. The problem is you need a short working distance in order to hold the foreign body. The one on the, here you see the forceps, the one on the left is the basket forceps, while the one on the right is the serrated forceps for large non-magnetic foreign bodies. Sometimes the foreign body is too large to remove. This is a recent article where they formed a basket using sutures and introduced them through a needle inserted in the trocar in order to place the foreign body inside it and pull it out. Another way that has been mentioned in the literature is the nitinol stone basket. Basically the same principle, and this is usually used by urologists to remove the stones from inside the ureter. It is a 19 gauge instrument. So after you remove the specimen, obviously you need to send the vitreous and the intraocular body for culture. And a lesson to learn is never to rely on visual experience when estimating the size of the intraocular foreign body. and thus the required length of the opening you need to incise in order to extract the foreign body. And as Dr. Bargi mentioned, that we need proper protection of core endothelium when you are considering a limbal route for extraction. And for encapsulation, the foreign body should be freed from the encapsulation to free it first from the vitreous attachment. Plus, for the intraocular foreign body magnet to work, it needs direct contact with the metallic foreign body itself. For intraretinal foreign bodies, there is a higher risk of PVR and epiretinal membrane formation. And for subretinal intraocular foreign bodies, usually they are hidden by blood. And in such cases, sometimes you might consider that the removal might not be of benefit, especially if when you do an ERG, and in such cases where the vitreous membrane is very dense, you may have a reduction in ERG, and this would be tricky to read. Prophylactic retropexy should be considered before fresh retinal breaks, obviously, and other complications like retinal attachment should be dealt with like in any usual case. This is a case of a foreign body that was not being able to be removed. You can see here a glass. This is tempered glass from a car accident. The surgeon couldn't remove the glass. It was very slippery, and it was prone to break every time he touched it with the serrated forceps. He didn't have the basket suture to remove then. This is unfortunately the same eye after it developed PVR and detachment. It was in a problem. So we'll go into the video. So this is a simple foreign body removal after releasing it from the vitreous attachment and removing the surrounding encapsulation. We remove the foreign body through sclerotomy. After shaving the vitreous at the sclerotomy site. So we should never actually pull the foreign body forcefully. And you can see here, I attempted that, but then it ended well by just increasing the infusion pressure, and it pushed itself out with some help. Another case. This is another case. Traumatic cataract. You can see the large corneal wound. So we had to remove the cataract first. I'll skip through this. Then we remove the remnant of the capsule in order to reduce the risk of PVR. Here you can see the vitrectomy. You can notice the foreign body encapsulated. Of course, we had to remove the posterior vitreous using the triamcinolone. Then trim around the foreign body, and then removing it through again through a large sclerotomy. We used the keratome blade, and this is the giant magnet in action. You can notice the difference in size. Usually outside the globe, you will find that the foreign body is much larger than when you see it inside the vitreous cavity. This is a case who presented with endophthalmitis. You can see the limbal root of entry. The eye was full of pus. We attempted the iris reposition. So after resuturing the wound, the view was not that good because of the vitritis, but eventually we found the foreign body. Just fill to the equator. We trimmed the vitreous around it. Then we inserted the intraocular body magnet in order to remove it through through a sclerotomy. Always be generous with the sclerotomy in cases where you are not sure about the actual size of the foreign body. And this out, and we switch to the sclerotomy. In this case, it was a foreign body along with the intraocular foreign body inside. There was a retinal detachment along with the intraocular foreign body, which was large, due to a broken screwdriver. There was a lot of vitreous hemorrhage inside the eye, which we needed to deal with. After removing all of the vitreous hemorrhage, and identifying the foreign body, we performed a sclerotomy and then introduced the serrated forceps, the foreign body forceps, to hold the foreign body. It was very large, and there was adhesions to the retina, so we had to release them bi-manually. We had the chandelier light in place. Then we had to enlarge the wound and use the giant magnet again, so you can see how big it is here. And there was some vitreous and retinal prolapse, unfortunately, with this eye, with this foreign body. But eventually we managed to flatten the retina with a large inferior retinotomy and laser the retina along with the silicone oil tamponade. And then suture the eye. This was the broken screw, part of the screwdriver that has been removed. Thank you very much.
Thank you very much, Prof. Marwan, for this wonderful talk and presentation. We have some question, Marwan. Some asking why you prefer the limbal rather than the scleral incision.
Well, as you have heard from Dr. Ahmed, that we aim to save the save injury or save the cornea from having to pass through I mean, the foreign body shouldn't pass through the cornea or injure the cornea. So I think that proper management is to remove it through the limbal route, through the pars plana, because then you can avoid injuring the cornea. In addition, if you had, for example, an IOL in place or a lens in place, then you are easily away from it, and then the cornea would be saved from unnecessary injury.
What about your opinion, Dr. Ahmed? Do you hear us?
Yeah, sure. Yes. I think,
scleral or limbal?
Personally, I prefer scleral or because you know what, usually as Dr. Marwan has illustrated in his presentation, that usually if you want to remove the foreign body, better to avoid the original wound. So if you have a big scleral wound, like 7, for example, my case, it was like 7 millimeter scleral wound. So you have, and you suture it and you keep it in place. So you want to remove it again. So you have to open another like 5 or 6 millimeter of scleral wound. And this two big wound in the sclera, in the long, and then in the long term, the sclera, the eye will be more susceptible to any minor trauma for rupture globe. We have a lot of incident of hypotony. So both technique, you know, it's you can do it, but each there is no technique that it's 100% safe or without complications. So at the end of the day, you decide, and there is only co and pros for any technique, you know. So
I think because it's a multi different stage and size.
Exactly. Yeah.
Different preference. For me personally, I prefer the limbal wound actually. If it's small, if it's big, I will use it through the sclera. Of course, to avoid the distortion, astigmatism caused by the incision for the corneal, all that stuff.
Yeah.
But at the same time, sometimes you don't want to damage the lens. If the lens is intact, it's always preferable to bring it through the sclera. So it's a different depending on the situation, as you mentioned. I was amazed with the magnetic tool that you have at Prof. Marwan. You have multiple magnetic and strong ones.
Yeah.
Yeah, sometimes you need them when it's difficult to hold them with the forceps you have, because not every forceps is suitable to hold the foreign bodies. We don't have the suture basket like the one I just showed you, the retinol basket, but you can fabricate one in the OR using the sutures.
The second reason I prefer the limbal is I want to see exactly where is the foreign body itself. I don't want to be hidden under the sclera. So I do handshake, bring it to the cornea and try to see it myself. Sometimes with the magnetic, when you suck it, you can scratch the retina in the cornea, in the peripheral place. Do you think it's could be happening?
This is with the giant magnet. With the intraocular magnet, now you can control it. There is much better control. But with the giant magnet, the old versions, the core of the magnetic field is far from the tip. So when you apply power, it can travel in any unpredicted way. But with the new ones, the tip has the core of the magnetic field. So when you apply it, it will travel in a straight direction towards the wound. If you put the properly place the magnet over the wound.
Okay. Dr. Alexandros, have you practiced any OCT over a foreign body to make sure you don't have any retinal tear? Your voice.
He's muted. Dr. Alessandro is muted.
Yeah, here I am. You can do intraoperative OCT in this case.
I think this will be wonderful. That's true. If you can bear the cost of the belt and
Well, you need
one of the advice for the attendees, maybe it's always better to use the visco rather than keeping the infusion open. Sometimes the flush with the waves of infusion, you can really move the retina, and if there is some small tear, you can really detach it. Visco inside the eye is very helpful. Sometimes we forget it. And I saw the chandelier you use, Dr. Ahmed. It's valveless, isn't it? I don't think the chandelier has a valve in it.
Chandelier, sorry, come again?
The chandelier, when you remove the fiber optic, is it sealed or it's valveless? I don't think there is a valve in it.
No, there is no. Once you open it, it's the fluid came out. Yeah. As I mentioned, I remove it just I want to get some fluid to go out because I'm going to enlarge a corneal wound. So there is hypotony. So you have to control the pressure and the posterior part compared to anterior part. So that's the reason I remove it.
Okay, unless our colleague has a question.
I just have one question for Dr. Alessandro.
Yes.
Since we have your expertise in the OCTA, you know, sometimes in our while we're treating the age-related the CMV, the neovascular age-related macular degeneration, and the chronic case, we sometimes found some fluid. You cannot differentiate it. Is it actually degenerative or exudative? So depending on the OCTA, so what are the signs that you can tell us or the attendees that if you find it in the OCTA, it means that this membrane is active need to be treated, and this fluid is not generative, it will be oxidative. It is the caliber of the vessel, it is the flow inside. Any, I mean, tips or tricks for that, just to, if you want to make sure about the
Okay,
activity.
if you can remember the image I show you from the, the last image from the Heidelberg. If you have a really high resolution, you can see these small vessels growing.
Okay.
When a CNV is not active, it seems like a tree, just with the principal ramifications. So as far as the CNV loses activity, you lose the small ramifications, the small vessels, and you maintain just the wide and the central vessels that are not active. Always you need to check, as you said, the structural or the B-scan OCT, the structural B-scan or the angio-CT B-scan, and check for liquid. So sometimes you say correctly, you can have subretinal or intraretinal liquid that is due to RPE failure.
Yeah, exactly.
And okay, but this I think you can find in really advanced cases with very low vision. In some cases, there is no more need for treatment. But from the other hand, in FA, in photoangiography, you have leakage. That is a sign of activity. Angio-CT is helpful when you have a follow-up. You need a baseline, and then you have a follow-up, and you need to repeat the scan the same place. And then you can see growing these small vessels when you have activity that are associated with intraretinal liquid. But as I told you, instead of the leakage, in this case, you have these small vessels. But if you don't have high resolution, you cannot see the growing of the new vessel. So some people, some residents, some new doctors say, okay, we'll do a quick scan with low resolution. I talk about Heidelberg now, because the other instruments, you cannot change the resolution. And if you do a quick scan with low resolution, you can miss this type of vessels, have no sense. So it's better you do a B scan, and that's all.
Okay. Thank you.
Okay. Unless you have something, Prof. Marwan, I think our goal for dedicating your valuable time, and in this releasing phase, we know that we all has been going back to work and not as free as before. So thank you very much for being with us. Thank you for all the audience staying with us till the end, and hope to see you again in a very safe condition. Thank you.
Thank you so much. Thank you. Have a nice day.
Abdullah, let me send my best wishes to Saumil and his family, that they are really close friends of mine, also his mother. I'm really, I hope the best for her.
We hope, inshallah, that she will get.
Thank you very much.
Thank you.
Thank you. Thank you, Abdullah.
Thank you very much.